Good morning, good afternoon, and good evening, colleagues. Thanks for joining us for this social and behavior change for service delivery community of practice meeting. Today's meeting focus is supporting provider driven change. We have a 90-minute session. Slide, please. So we will have interpretation. Click on the interpretation icon at the bottom of your screen, select your preferred language. And we have English, and I think all presentations are in English. I'm not sure if there is. So pour les francophones, cliquez sur l'icône d'interprétation en bas à droite de votre écran et choisissez votre langue préférée. Et s'il vous plaît, les présentateurs, essayez, the presenters, please speak slowly so that the interpreters can they have enough time to understand and translate. Slide, please. Here are the co-chairs that delighted to introduce. We have two new co-chairs. Before I will introduce the one you know maybe, Kendra Davis, she's program officer from J2CCP, Breakthrough Action. Heather Hancock, also senior program officer, Breakthrough Action, J2CCP, and myself, Sige Plea, I'm technical director for Guinea program working for JPIGO. I'm delighted to introduce the new co-chairs, Mania Dodson, who is the director of SBC and Applied Design, working for JPIGO, and also Amy Dickerson, technical management officer, Momentum, country and global leadership, JPIGO. Slide, please. We have some announcements to make. There is a conference in November 18th through November 22nd in Japan, Nagasaki, Global Symposium of Health System Research. Please put us in the chat if there are people who are attending or presenting, let us know. And also there is a tool, the video developed. There will be two sessions in July, one on the 16th, the other one July 18th. Virtual question and answer sessions, and you'll have the link on the chat. Also, there are expression of interest for two-part virtual consultation on pleasure and SBC focused on gender equity. This is the follow-on on our last community of practice meeting on gender. And this will be a two-part consultation for people who are interested. And also, the point will be how to discuss it to integrate pleasure better into programming. And the expression of interest will be sent via the Community of Practice mailing list, and you'll have the link as well. And there is a PBC toolkit adaptation and implementation package to help you learn from your experience using and adapting the PBC. Heather, please put the link for future use. Slide, please. There is a Knowledge Cafe. It's a learning event. It's on September 9th. Please respond to the short survey, which is focused on what kind of topics to explore you are interested in, and identify tools you'd like to learn more about, and volunteer, please, to share a tool. Slide, please. So let's go back to our session. The session objectives are, there will be, we'll be sharing, there will be discussion on results from you, the Community of Practice Sustainability Survey, and learn about the 3 great programs working to support provider-driven change to improve service delivery, one from our colleague from PSI, Breakthrough Action, and JPIGO. And we'll have an opportunity also to discuss opportunities, how to incorporate provider-driven change into community of practice members, social and behavior change, and health system strengthening and or service delivery programming. Slide, please. So our program, as I said, we have a 90-minute session, and we'll have the 3 presentation, as I said, and also we'll have Q&A sessions and some discussion, and we'll wrap up on time at 10 o'clock. So over to you, Kendra, for the next session. Thank you.
Thank you, Sige. Good morning, good afternoon, good evening, wherever you're joining us from. I'm going to do a little section that we just started this year called Connecting the Dots. Next slide, please. So I'm going to help connect the dots for how this meeting relates to different resources that we've developed under the community of practice. So firstly, we have our shared agenda, which kind of helps the COP prioritize different areas. So the overall community of practice aims to establish and maintain a shared agenda to unite practitioners and decision makers around priority areas in social and behavior change for reproductive, maternal, newborn, and child health and service delivery. So today's meeting, we will focus on priority area number 2, provider behavior change, which aims to support community and facility-based providers in the public and private sectors to improve client health outcomes by addressing factors that shape provider behavior. These interventions may engage directly or indirectly with providers to address individual, interpersonal, client, community, workplace, health systems, and country or geopolitical factors that impede or facilitate positive provider behaviors. These implementing social behavior change for service delivery interventions need to better understand the full range of factors influencing provider behavior and design initiatives that address those factors. Our goal with today's presentations and discussions is to learn about successful provider-supported and provider-driven behavior change initiatives at the facility and community levels. Next slide, please. And this is the circle of care model that was also developed under the community of practice. And it helps it work towards established priority areas for the COP using a holistic model. The circle of care model shows how social and behavior change can be applied across the service continuum. So in the before, during, and after stages to improve health outcomes. So just to break it down a bit, the goal for the before stage is to capture attention of clients and them to access services, create an enabling environment that can be done through mass media campaigns, community dialogues, or outreach with community health workers or providers. The goal of the during stage is to improve overall client-provider interaction, which can be accomplished through client-provider pledges, client self-efficacy tools, or training and supervision of providers. And lastly, the goal of the after stage is to enhance adherence to medication and maintenance of health behaviors, particularly healthy behaviors, through digital follow-up, home visits, and support groups. The presentations given today will share examples from all 3 stages. As we listen to today's presentations, please think through where within the circle of care the various interventions fall, such as, are they creating an enabling environment for clients and providers, motivating them to seek and deliver quality care? Next slide, please. So before we dive into the wonderful presentations we have today, I first want to go over the results from a sustainability survey that was launched a few months ago. And this is following an impact survey that we launched last November. So during the month of November, we asked COP members to complete a survey to help the co-chairs understand the impact of the COP and what it has on members' knowledge and understanding in the area of social and behavior change and service delivery in regard to reproductive health, maternal health, child, and newborn health. And for that survey, we received 30 results. And following on that, we dug a bit deeper in the sustainability plan survey just to understand what are the priority areas of members in regard to what they want to see in leadership, the structure of the COP, the funding mechanisms, and what components of the COP are priority areas for members. So now I'm going to present some of the results before diving into a few questions. So firstly, on the structure, many members were in agreement. So I guess I didn't share yet. We had 40 members complete the survey, and 100% of the respondents agreed that the COP should be co-chaired by 2 organizations. Currently, the COP is co-chaired by Breakthrough Action and by JPIGO. And then 95% of respondents agree that the COP should continue to develop one knowledge product annually. So for example, last year we developed the Provider Behavior Change Compendium, which a lot of the work in designing and vetting a lot of the materials came from the co-chair organizations, but we did ask for input from members. And then lastly, in terms of structure, 78% agreed that the COP should host at least 3 annual meetings. Other responses were to hold either 2 meetings a year or 4 meetings a year, having 1 meeting every quarter. Next slide, please. Next, we asked what the co-chair structure should be. As I shared, the 2 co-chairs of the COP currently are Breakthrough Action and JPIGO, which provide an SBC and service delivery expertise. And so now I'm going to launch a poll to ask some follow-up questions. And we're just asking follow-up. So we had an open-ended question for folks to fill out, okay, what type of organizations are best placed to lead the COP? And many people responded an SBC focused organization, a youth-led organization, a non-US based organization, a research institution, a multi-stakeholder networks, or community-based organizations. So now I'm opening it up to all participants in today's meeting to vote on which type of organization they think is we should prioritize when looking for new representation in our leadership. So leave this open for a bit more. We're at 25% of participation.
Kendra, can you give us an example of a multi-stakeholder network?
That is a really good question. A multi-stakeholder network, Heather, do you have an example off the top of your head for that? I can't think of one right now.
Perhaps like the core group or something like that.
Yes. Is everyone familiar with the core group?
No, I think some people may not be familiar with the core group.
Okay, I will place their information in the chat just for an example. And we're currently at 58%. I will leave the poll open for another 30 seconds. So I pasted the core group in the chat if people want to understand that example a bit better. So we're about at 60%. I will end the poll. And it looks like overall 61. Oh, I'm sorry. I just closed the poll. So there's no more voting for this poll, but we have more questions to follow up on. But it looks like overall 61% agreed that an SBC focused organization should be prioritized, followed by community-based and then a multi-stakeholder network. So we will definitely take this into consideration when writing our sustainability plan. Okay. Thank you, Heather. So now we're going to go into suggestions for restructuring the COP. So this was an open-ended question. We asked members to share in addition to some of the questions we asked about current structure. And so ways the COP Secretariat can improve the COP structure to meet members' needs. So additional technical support, stronger engagement of leadership from service delivery partners, engagement of health system strengthening partners, which I will say is a new priority area and is something we have tried to incorporate this last year, but is something we will definitely highlight in the sustainability plan we are currently working on. Other things members suggested was having more regional representation, training and capacity building, networking, and field visits, as well as organize an annual in-person meeting. And I do have some discussion questions at the end of this presentation, to dive a bit deeper into these suggestions. Next slide, please. So opportunities, no surprise here. Most members that completed the survey said that they want to see more capacity strengthening opportunities for the COP, as well as occasional networking opportunities. And so one question we have for members is, what does that look like? Is this on an annual basis? Would this be hybrid or virtual or in person? So this is something we will also dive into a bit more in the discussion section, but just keep this in mind, these results, and start percolating a bit of how you would want to respond to this. Next slide. Thank you, Heather. So COP funding. As was shared in the survey, currently the COP is funded 100% by USAID through projects like Breakthrough Action and Momentum. However, there's no guarantee that this funding will continue forever. So we were looking for additional ways that we could find support to continue the COP. And so some suggestions that members who complete the survey gave were different government funding from different governments, funding from international organizations such as the World Health Organization, United Nations Development Program. Another suggestion were member fees, as well as corporate funding. So I'm going to launch another poll. And in this poll, we're just asking for more suggestions you may have for additional funding sources. And so this is an open-ended poll, and you can just share whatever ideas you may have for additional funding sources. So I'll leave this open for about a minute before continuing.
Kendra, I'm seeing, I don't know if anyone else is having this experience, but I'm seeing the question, but I'm not able to answer it.
And I'm not even seeing the questions. I'm just seeing a blank white screen that says polls.
Oh, no. Okay. Well, maybe in the chat, could people respond to what are additional funding sources or methods we should consider to support the future of the COP? That would be great.
Hello, is this besides the ones that we have projected or we are
Oui, on a
picking from
l'écran,
there?
on voit, mais les questions sont en anglais, bien sûr.
Ah, d'accord. Désolé.
C'est affiché.
Yes. So I will add it in French. And in the discussion section, I will add the translation in French for you all to respond to. But to the other person's question, yes. In addition to the funding sources we have listed, are there additional funding sources? Sorry, I went on mute. Next slide, please. So to wrap things up, thank you, Anne. some of the COP, 97% of respondents agree that the COP should continue to develop a shared agenda every 4 years. But there are many other components within the COP that we prioritize, such as having annual meetings, developing a knowledge product, and having the listserv. And so I'm going to launch another poll. Hopefully this one works. Let's see. And this one is asking people to rank what components of the COP we should prioritize. Essentially, depending on funding, there may be things that we need to advocate for when developing the sustainability plan. And so we are asking you, the members, what we should prioritize. So 1 being the most important, and 4 being the least important, to vote on what things should we prioritize for the COP moving forward.
So what is the complete sentence for the second option? Member list save?
Yes. So we have a listserv. That's how we send emails and notifications about meetings or different resources. And so is that something that we should prioritize, maintaining the
Okay.
member listserv? Yeah.
Thank you.
Good question. We're at 36%. I will leave this open for another 30 seconds. Any final responses? We are at 40, we're almost at 50%. Okay, so I will end the poll now and share the results because we have about 5 minutes left and I want to leave time for the discussion section. So according to this poll, it looks like we should prioritize the COP shared agenda, and the knowledge products are 2 of the things that people ranked as the most important, followed by member meetings, and then the listserv. And sorry, another thing I did not mention that is on this slide are priorities that members are working on. So we created a word cloud of what members' inputs were, and it looks like a lot of members are currently focusing on provider behavior change, health system strengthening, and health service referrals. Next slide, please. So in the remaining 5 minutes for this section, I will open up the floor to ask if people have any reflections on your own personal experience with the COP. Would you agree or disagree with the results shared, as well as do you have any thoughts on the information that has been shared so far? You can raise your hand or type a response in the chat. Yes, Anne, please go ahead.
Hi, thanks. I guess I will just share the experience we had at the end of the maternal and child survival project, where we did co-chair with other organizations, a couple of communities of practice, including the Family Planning Immunization one and the MICIN, the Maternal, Infant, and Young Child Nutrition and Family Planning Community of Practice. What we did is, first of all, we had a reflection exercise similar to this one, including one with the two communities of practice together that were joined, and we recommended forming a joined community of practice. And then we sort of articulated the recommendations for that community of practice. And then we presented it to colleagues at USAID who at that meeting, not to embarrass anyone in this room, but at that meeting were very quiet, knowing that there were some procurements for what ended up being Momentum in process, so they couldn't say anything. But at the same time, they sort of appreciated us sharing sort of the group's recommendation. And then once Momentum was awarded, we were told that we were given a list of communities of practice, including this one, that we that they hoped, you know, core funds would help to facilitate or co-facilitate, including the joined up what we are now calling the MICIN FP immunization community of practice. So that's just past experience. So there may be sort of a period of lull between awards. At least there was back in the day.
Thanks, Anne, for sharing that experience. It's very interesting. And I see someone shared a Rotary co-chair from Key Government Representative would add value and visibility. We will definitely keep that in mind as an option. Sorry, just pasting this in the notes. So we have about 1 minute left. Sorry, I did not leave enough time for in-depth discussion, but I want to open up the floor, and you can add to the chat throughout today's meeting or email me personally or other co-chairs. But how would the ending of the COP, if that were to happen, I'm not saying it is, impact the SBC, service delivery, or health system strengthening work you do for your organization, country, or region? And while we wait for responses, Katrina, would you like to come off mute and share a bit more about your comment or suggestion?
Sorry, I do have to pop to another meeting, so I'll just keep it really brief. Yeah, around micro-solidarity, just kind of some newer emerging kind of research and understanding about how to kind of create community. And we often start from this big, you know, invite everybody, have this huge kind of community practice. There's a couple hundred people on this list. But many people find that really intimidating, and it doesn't actually create the kind of community that I think we're really seeking. And so this micro-solidarity approach is really like starting with pairs, you know, starting with one other person in the community, and really
I'm not sure if
intentionally
it's my
building
internet
it from
connection, but I can't
pairs.
hear you anymore.
Of course. Oh, sorry.
I can hear her fine.
Okay.
It's your connection, Kendra.
Yeah. So anyways, moving from very micro connections and slowly building. So as you're thinking about the structure, you know, thinking about ways to do, you know, intentional pairing, buddies, those kinds of things, you know, building up to small groups within the whole community, and then eventually building up to the whole community, you know, a larger community of practice. So kind of thinking about that. And then, you know, definitely the other kind of pieces, is really, and I think you do this as well. We're learning to do this more, but it's just making sure that that the knowledge comes from all, you know, directions, right? So it's not, you know, knowledge that is aggregated and held at the global level, but that there is a lot of rich country to country sharing, country, you know, to global sharing, and just kind of, you know, increasing that kind of rich body of knowledge that is across, you know, many different levels and dimensions in our community. and I'll hop off here. Thank you for including me.
Yes, thank you for sharing, Katrina. And I just want to highlight one more comment before I pass it off to the next section of today's meeting. Someone shared that regional representation will enhance inclusiveness of diverse cultures and social behaviors considered in best practices and learnings, which I completely agree with, and we will definitely capture in our sustainability plan. I will now pass it off to Heather to introduce our presenters.
Thanks so much, Kendra, and thanks everyone for sticking with us because there are some really interesting presentations. We're really excited today to hear from 3 different presenters about how we can better support providers to see provider-driven change and support them in their mental health and their well-being, because that is something that, of course, we are seeing a lot, that there are some really big struggles with providers and their well-being. And so we have presentations today that focus on this. And as we dive into these presentations, we hope that people will keep in mind the whole system, kind of the ecosystem that supports providers, and that it's not just up to providers to make these changes and to ensure that they're supported, but that we need to look at the whole system to ensure that they have the support that they need to take care of themselves and also to move forward changes in their own environment. And so we need to see a combination of those things. So we will hear from 3 presenters today. The first will be Sean Malone, who is from PSI South Africa, and he will be presenting on co-creating a new model of person-centered care with healthcare providers in South Africa. And then we will hear from Lynn Van Lith from Breakthrough Action, who will present on a compassionate care activity in Tanzania. And then we'll hear from Aissata Ba and Aissata Ba, who will present from a project from Jhpiego, Club Courage. So over to you, Sean.
Great. Thanks, folks. And thanks so much for the opportunity to talk with you today. You can go to the next slide. So the origin of our work was really looking at why we haven't been reaching men. And so, as you can imagine, we uncovered in talking with men a lot of reasons why men don't like the clinic experience, don't like the interaction with providers. And I think the point of this slide is it candidly put us in a little bit of a judgmental mindset about providers, that in a lot of cases, they're a problem, they're a barrier, there's something that we need to fix or solve for. And thankfully, we followed up by talking directly with providers, and that shifted our perspective a bit. Next. So if men said, look, the clinic is not a happy place for me, what providers told us is the clinic's not a happy place for me either. It's not supportive, it's not empowering. We have the same frustrations or similar frustrations that patients have. And when we really sat down with providers, they walked us through a whole list of which we've captured the main things here. Some of them practical in terms of workload, admin, reporting. Some of them more psychosocial in terms of feeling valued and appreciated and supported. But really, for us, the bottom line was that it helped us to build a lot of empathy with providers around the challenges that they face and starting to get an understanding of what they might need. Next. So as with men, we uncovered a lot of stereotypes and misconceptions about providers. I will not walk through each of these. You can hopefully access the deck another time. But I think we see this about a lot of the populations that we're trying to serve, that we're often operating on stereotypes, assumptions, misunderstandings, until we actually make the effort to go and sit with them and understand them and figure out what things look like from their perspective. And so we were fortunate to really, I think, surface a lot from providers on the way that they feel often misunderstood. Next. There's another slide of misperceptions, again, that folks can go through on their own. Next. So, when we started thinking about solutions, we looked around the sector, and unfortunately, I think sometimes what we see, and thankfully less and less, is this idea that person-centered care and quality of care from providers depends on monitoring and accountability and enforcement. And we are going to keep an eye on those providers. And when they mess up, we are going to call them out and we are going to make them behave. Really, the perspective that we got in talking with providers is they already feel overburdened. They already feel beaten down. Yes, there is a percentage of providers who probably should not be in this profession, but I think most providers said, I really am still here. I want to do well. I'm trying my best. I realize that I don't always reach that benchmark, but I would like to do better if you could give me something that felt supportive. And so that was really what we set out to do, is to see what resources and support we could give providers that they could feel good about at the same time that it hopefully improves the care that they're giving. Next. The topics that we built the model around are ones that providers themselves identified for us as enablers of better care. And I think some of these are quite obvious: empathy, communication, patient insights. I think we all know when we're focusing on that patient-provider interaction are important things to strengthen. We also went a little bit upstream, and clinicians said, if I'm not managing my own stress well, if I'm not working well with my team, if I don't have good leadership and support from my supervisor, it also makes it much harder for me to give good care to patients. So we added those elements in as well. Next. Providers also gave us a lot of thoughts on how to structure this, apart from the content, how to structure it in a way that would be feasible. And so they told us things like focus on practical knowledge and skills. We don't want academic theory about motivational interviewing. We want to know how to do it. They also said, bring in people who know our day-to-day, who know the challenges we face. Don't bring in folks who've never walked the journey that we're on. So we found a couple of nurses who have come in and led this work with us. They also said, by the way, don't call them mentors. It feels very formal. It feels hierarchical. We would rather feel like there's someone that's on our level. So we actually came up with a different local language term for that. Avoid once-off training and cascade approach. I think we probably all know that never works, but somehow that keeps happening, I think, in the face of other constraints, where we think somehow things will magically cascade down. Don't pull people out of work, rather bring support to them in the workplace. And then feedback, we were really surprised. Providers said, feedback is fine. You can tell me where you think that I could improve. But one quote we got from one of the nurses was, you can name it, but please don't shame it. I think one thing we've also learned is shame is just not a durable motivator. Next. So this is the cycle we've been going through, starting at the top with a 1-hour training per week at the very beginning of the day on some aspect of person-centered care. And from there, what's perhaps a bit different is the mentors stay around. They spend the day at that facility observing and debriefing and coaching and really helping providers to put the things that they're learning into practice and hopefully embed those. We're following that with measurement of clinical outcomes, but also patient experience and provider experience to see whether things are starting to shift. And then we're putting that data right back in front of the clinic team. So that data is not primarily for anyone up the chain. That is really for the clinic team themselves. And then lastly, for teams that are progressing, we're trying to find ways to celebrate that and recognize that and help people feel good about that. Next. What we've been seeing is pretty complex, but what I think I would highlight for this group is that the clinic teams have been surprisingly open to engaging in this kind of work. I think the challenges have been largely on the operational or logistical side of just figuring out how to slot it into their day-to-day routine. But we've really been happy. Some folks told us these nurses will not want you there. I think that's another misperception. Next. As I said, we've been focusing on not only clinical indicators, which I know everyone's ultimately accountable for, but kind of some of the interim things too of our patients feeling better about their experience, our providers feeling better about their experience, and can that lead to better outcomes? Next. So we've been doing a quarterly survey with providers in the facilities and with patients, and really happy to see some of the improvement over baseline. One thing you'll notice, some of the numbers at baseline actually were not that bad. It's not that the clinic is always a horrible space for everyone, but we are happy to see that some of the indicators that we wanted to see going up are going up. Some of the ones that we were hoping would come down are coming down. That's not to say there aren't challenges, and if I showed you the full graph, you'll see the blips between these two figures, but we are seeing overall, I think, an encouraging trend. Next. We're also doing in-depth interviews with providers and with patients, and again, hearing some really encouraging things about acceptability among providers, and as well as their stories of how this is changing the way they interact with patients and the way they interact with each other, and how that's making their work better. So we have pages and pages of these. I actually had to chop these down just to for the sake of time, but really some tremendous feedback from providers on the way they're experiencing this. Next. We're also getting, I think, some good feedback from patients on ways that they're seeing positive change in the clinic around specifically the areas that we care about, around active listening, giving enough attention, giving enough information, feeling respected, and feeling like there's privacy and confidentiality in the clinic space. So also seeing good things on the patient side. Next. So that's the model in a nutshell, just acknowledging all of the stakeholders we've worked with. I think in particular, the clinic teams. I really can't say enough about the experience we've had with the clinic teams who've really embraced this model and helped us to create it in a way that works for them. So really grateful for that partnership, as well as partnership with the Department of Health and our funder and a couple of other key folks who've helped us to build this out. So thanks, folks. I look forward to any questions or feedback you might have. That's it for now.
Thank you so much, Sean. And for everybody, if you have any questions or comments for Sean or any of the presenters, please do put those in the chat and we will address those after the 3 presentations. Okay, we will go over to Lynn now.
Super. Thanks, Heather, and thanks, Sean, for that great presentation. I'm going to touch on some similar themes. So yes, the focus of this particular intervention is looking at how to apply the different sections within the provider behavior ecosystem and try to increase and improve experience of care for clients, as well as the workplace environment and many other factors related to providers. So on the next slide, there's been a great amount of work already done in the respectful maternity care space, though perhaps a little bit less in that period after childbirth. So this intervention and the associated study is really looking at kind of an extended postpartum period up to 1 year after childbirth, building on a lot of the literature and the great work already done. And so the focus here is really trying to better understand what existing evidence there is around how the benefits of providers showing more empathy and practicing more compassion can be translated into improvements in experience of care for clients. And so there is a growing body of literature around this. And the beauty of it is that not only does it improve experience of care for clients, but there are huge benefits to providers as well. And so again, some of that literature has shown that there is increased job satisfaction, reduction in burnout, and general happiness, more happiness in the workplace when compassion is a key part of it. And we know that small acts of kindness and human connection can make a huge difference in our own workplaces. And this is no doubt true in health service settings as well. So on the next slide, essentially, I'll walk you through very quickly the process we followed. We conducted a rapid desk review, reviewing the literature, and tried to map that literature against the provider behavior ecosystem. Many of you may already be familiar with and know that the provider behavior ecosystem was built on the family planning literature. We have now, under Breakthrough Action, expanded that to look at the literature related to malaria outcomes, as well as maternal, newborn, and child health. And then we held a consultation with maternal, newborn, child health, and nutrition experts around the world to really talk through the findings and map that out. So briefly on the next slide, I want to share, we developed, again, we used the provider behavior ecosystem map and looked at each of those components and the factors. And on the next slide, you'll see that we identified 32 factors within the system that very much have an effect on experience of care for clients. And we looked at some of the issues related to and the factors related to provider well-being and provider satisfaction. So I won't go into all of that. And again, we'll be publishing more of this when we have results of our final study. But on the next slide, the next step then was co-design. So we applied a human-centered design process in Tanzania and worked hand in hand with the service delivery partner there, the project called CPRC, led by AmeriCares. And this particular project is focused on faith-based private sector facilities in Mwanza region. So they worked in 10 facilities. And so we co-designed on the next slide, we co-designed the intervention components with providers and a range of providers. So we invited in charges, doctors, nurses, but we also invited medical assistants and sort of people at different cadres, different levels, and therefore with different power in the health system. And we also invited the Ministry of Health. You'll see the gentleman on the far left of your screen is Dr. Sunday. He is a co-investigator on the study, as is the chief of party for CPRC, Dr. Jean Fouli. Both are co-investigators on the study that is underway now. So on the next slide, I want to share with you what the providers themselves came up with in this human-centered design workshop. And so there are 7 components, which may sound like a lot, but some are quite simple. And I think we've learned now with systems thinking that, you know, trying to shift just one element in a broad, complex health system often doesn't yield all that much. And so we did really want to address several of the factors in the provider ecosystem. So the first was sort of an additional training. There is, of course, a Ministry of Health supported and recognized national respectful maternity care training. We tried to do an additional bit that really focuses on practice, compassion, as well as skills around giving and receiving feedback. The health system structure is fairly hierarchical, where, you know, information comes down from on top and reaches people at the bottom, but very rarely is some of that feedback then kind of cycled back up. So we heard firsthand from providers that many don't feel comfortable sharing feedback with their in charge, that really is counter to the health system and the way they've been trained. So we wanted to try to flip that on its head a little bit, test this in the private FBO facilities. And again, the Ministry of Health is involved throughout, and we are operating through Ministry of Health structures so that should the intervention show some success, it could be scaled. So we very much planned for that from the beginning. The second element are self-care practices, and we wanted to build on the great work from Breakthrough Research. They did a lot of interesting work around provider behavior change, some studies, one in Kenya, and developed this wellness package. And so we took that and tweaked it. The second visual here is that poster in Swahili. We adapted it a little bit, but the purpose here was to really ask providers, how can you imagine self-care for yourself? Recognizing that not all, you know, mindfulness techniques may translate, and that we wanted to really hear from them in the Tanzanian context, what would be feasible. So there's a bit of self-care package within that second intervention component. We also furthered the client feedback system, and the third visual there is part of that. It's just a very simple visual with 4 components with sort of smiley face, sort of a neutral face, and an unhappy face, so that clients can circle one of those. And then the fourth component is that these client feedback forms are collected monthly, and then the facility will look at the feedback from clients with the provider's name on it, and then choose a compassion champion of the month. So who within a given facility is really demonstrating and leading with compassion? The fifth element is a provider self-assessment, that we don't want only external assessments from mentors, but we want providers themselves to think about how their behavior has changed, how the facility may be changing, and what the outcomes are of that. And then the sixth element is very much around ongoing mentorship and supervision, and the mentors from the Ministry of Health are leveraged for this purpose, and they have additional support. I should have mentioned my colleague Juliette Sizia was not able to make this presentation today, but she is working very closely with those Ministry of Health mentors to make sure that the compassion support is there. And then finally, the client charter. This is nothing we developed. The Ministry of Health in Tanzania, of course, developed the client charter and all of the rights. And so we just simplified it to put it into a very visible poster so that clients could see it in their facility. So on the next slide, I just want to talk through, this looks a bit more complicated than it is, but I wanted to map out the 7 intervention components I just shared, and looking at both the provider outcomes that we are measuring in the study, as well as the client outcomes. And I'll talk more about this later. On the bottom, you'll see a yellow bar. We also conducted a human-centered design workshop with community members, and there is an entire different sort of accompanying complementary package that is also taking place at the community, so that clients and community members are also aware of their rights, what's in the client charter, and know what to expect and ask for when they go to these facilities. So I want to just quickly touch on the last couple of elements here on the next slide. Our sort of final piece right now is we conducted the baseline and are carrying out the 6-month intervention now. And on the next slide, you'll see the objective, which is to really measure whether this multifaceted, compassion-focused intervention can improve experience of care for clients, and if it can improve job satisfaction for providers. So on the next slide, we conducted a pre-test, sort of a 2-month trial of these 7 intervention components, and then really try to see what needed to be tweaked, because even though providers designed the intervention, we needed to see how they really worked and if they performed in facilities. Then we brought the providers back together for an adaptation workshop and paused to see what needed to be tweaked based on the learning from their experience. And then we conducted the baseline, which included provider interviews and client interviews, as well as now carrying out the 6-month intervention. And the end line is planned for later this year. So on the next slide, I am nearly there. You can see here the client outcomes, again, mapping the provider behavior ecosystem with the intervention components, looking at client outcomes and provider outcomes. And next, I just want to share, and again, we'll be sharing much more of this when we have the completion of the study, but we really leverage the WHO compassion rounds and the compassion measures toolkit, as well as several other momentum projects, including MCGL, based on some of the work that they are doing in this space as well, and use some of the same questions and protocol that they had used, as well as AmeriCares. So again, you can see the different measures here. Most of them are validated scales that we tried to leverage. And next and last slide, just to share one more slide. These are the list of the various intervention and comparison sites, including the number of staff that are being interviewed. And we try to identify here a mix of hospitals, health centers, and dispensaries to see how the intervention plays out at different levels of health facilities, whether they're high volume or low volume. And then finally, the last slide, please, just these next steps. So as I mentioned, the intervention is currently being implemented for 6 months. We will conduct the end line in November and be able to share all of the findings in December. So that was rather quick, but a highlight, and we'll be sure to share the findings later in the year. Thank you.
Thank you so much, Lynn. We look forward to hearing more about the results. Our final presenter will be Aisata, also with Elizabeth Doggett. Sorry, I forgot to mention her earlier, but I will turn it over to Aisata. Thank you.
Thank you. Hi, everyone. Can you hear me? Okay.
Yes.
So thank you for having me today. I will be presenting about our experience in human-centered design in Mali through a project we call the Club Courage in Mali and Convocare in Ghana. Slide. So before we did the prototyping, what happened is we did some research in Mali with ThinkPlace to find out what are the needs and how we can help improve maternal health care. During that research, midwife expressed really experiencing a lot of stress, emotions, and trauma, and sometimes even anguish. So they told us that they work in an environment where they lack the tools they need and also the support, but mostly they work long shifts and sometimes they have very few staffing. And people who come at the health center from the community, like pregnant women or their partners or mother-in-laws, they expect the midwife to be the expert of everything and also not show emotions or show that she's tired or overworked. So this created really a lot of stress for them. And we at Japaigo, we wondered, we asked ourselves, how might we create a system in which midwives are better able to deal with their own emotional and traumatic loads, because we know when they are stressed, it affects their work. So from there, and like I said, we use the human-centered design to create a prototype we call the Club Courage. And this Club Courage is a meeting where midwife can meet at the health center or in the community at a colleague's house or anywhere they choose, at a local park or something like that. So what happened is, like, we use the existing groups, and the card will be used among 8 to 12 midwives. So they create small groups where they use those cards we have created through the human-centered design. And the cards are very low cost and very simple to use. And it provides them a space where they can support each other and provide each other with emotional support through sharing their own experiences. So it's just like a very informal meeting. When they meet, they draw from the cards that are in the kit, and also they discuss among themselves. So one of the most important aspects is, like, we don't need an extensive training to be able to use it. And it's divided in 4 thematic areas. The care for the midwives herself, for her family, for her clients, and finally for her colleagues. So this is an example of card. You can see in the front page, we have some questions that the facilitator will ask the group, and participants will share their own experience, their own feelings, and contribute. And sometimes if it is emotional, they can provide emotional support to each other. And also it can be in a technical area with a stressful event that she couldn't deal with, and the colleague shares their experience and how they think she should deal with it. And the back page, once the participants share the idea about the questions, in the back page, the facilitator will read these tips for them to deal with the question that was asked, and also remind them about with a statement that is very important to help them deal with their emotions and stress, and also a stressful work environment. So when we designed, we did a pilot study from December 2022 to May 2023. So what happened is, once we had the concept and tried it, we refined the cards with changing some content, adding some mental health components for using the Johnson & Johnson tools. And once we did that, we translated in French to be used in Mali and English in Ghana. So in Mali, it was just a reintroduction, while in Ghana, it was a first time use. After this, we did a programmatic study. So the study happened after 5 years of implementation of the meeting. Through the study, we wanted to describe the experience, acceptability, and self-reported well-being of participants in the Club Courage. So we are hoping to publish soon the results of our programmatic study. Okay, so 5 months instead of 5 years. So what we found out during this after 5 months of implementation is like it's allowed midwife to find out about their own emotion, their mental health, and also as a result, it allowed them to improve their communication among themselves and how they can deal with each other when there is an issue and how they can support each other. For instance, a midwife in Mali told us, like in a work environment where most of the time people are angry at each other, they don't talk. She said when she participated in the Club Courage, to quote her, I used to stop speaking to colleagues I was angry with. I have learned to discuss and address those challenges thanks to the experience shared by members of the club. I have learned to improve my stress management from how others handle the verse. And another testimony that was from Ghana is a midwife told us through ConvoCare for colleagues module, we have learned that when you meet a colleague who is suddenly withdrawing, you know how to address the person or the issues. We wanted to suggest that we hold one of our meetings outside our facility, like the beach, but I couldn't come. However, my unit on holiday to distress. We talked, laughed, and had a lot to eat. The next day, we came to work very refreshed. So this is a proof that when they meet, they can help each other's and they will understand each other's feeling and it helps them in their work. And the final quote I wanted to cite is from a Malian midwife. She said, now with the entertainment and the fun of the club, people are more motivated to attend. So it was in a context where people wouldn't attend the usual meeting, but since they had the Club Courage, midwives were attending their meetings. Next. So we faced some of the challenges. It's sometimes difficult to have all the most of the midwives to attend because they have different time schedules or different preoccupation. That was one of the challenges. And also the understanding is not everyone will participate in the meetings. And most importantly, the location, because some midwives don't live near to where, so transportation was a problem. So that's some of the issue. And also having refreshment has been raised as an issue, but all these are proposal of how we can do that by providing them ways to meet in a rotative manner and provide them with refreshment, and also allow people to be facilitator of the meeting. And at Japago, we are considering digitalizing the card to make it more accessible instead of printed versions. So to sum, I will quote a midwife from Ghana about her feeling in participating. She said, when you are stressed and the clients comes, you are likely to displace that stress or anger on them. But now I have realized that if I deal with my stresses well, there is no way I will displace them on the other persons. I realize they are with issues of their own. So this sums the whole idea behind Club Courage and how it can help midwife. Yeah, so thank you very much for listening, and any questions are welcome. Thank you.
Thank you so much, Aissata. It's wonderful to hear from you. I am going to hand it over to Manya, who is going to facilitate our question and answer and discussion section of this meeting.
It's good to unmute. Thank you all of our presenters so much. These are very rich interventions and we asked you to present in a short amount of time. So I know that there's many questions, but it's so exciting to me, first of all, to really recognize that the way that a person is behaving in a situation is contingent upon so many different factors. And I don't know how many of you have worked in healthcare facilities. Maybe if you can like put a little reaction, maybe your thumbs up if you have worked in a healthcare facility, and particularly one that is not necessarily highly resourced. I think all of us who have done that understand how incredibly stressful it can be to, you know, all of the different dynamics that are going on in that environment. So I have a targeted question for each of our presenters that I'm kind of seeing a little bit of questioning in the chat. And then I have a couple of questions for everyone. So my first question is for Sean. And Sean, and please, if you have other questions, if people want to ask questions, please raise your hand and we'll jump to your questions. I thought I would just get the ball rolling. So Sean, my first question is for you. And what do you see, or can you please tell us what the topics are of those different 1 hour to 90-minute training sessions that you do once per week?
Sure, Manya. Yeah, thanks for that question. We've got a total at this point. We've got a total of 16 modules. Just to give you a little flavor, here's one thing we do with the providers is just to go through the patient journey, and in addition to this, we've got a set of cards that asks the clinic team to reflect. What is the patient feeling at the point when they engage with the security guard, and what could the security guard say that would help that person either to feel better or or cause them to feel worse, and we go through that entire journey with the full team. Just as someone was pointing out in the chat, just to say there are so many touch points between the system and the client, and every single person has a role to play. So that's one example. The other one on communication, we've got simple mnemonics like always remember your pearls, partnership, empathy, apology, respect, legitimacy, support. We really tried to take things that are kind of easily digestible and remembered and practiced, and we've also developed some job aids that that we've left with providers to try to help them refresh when they need to refresh. But really, I think empathy, patient insights, and communication have been the key patient-facing ones, and then stress management, mental health, and teamwork on the more back office side.
Great, thanks, Sean. And the last time that I heard you share about this intervention, I heard that I loved that you were addressing teamwork and self-care, and there were many things that you guys were doing. So it's please, I really encourage everyone to follow up with Sean and learn more about the specific topics that are in each of their sessions. I think there's a lot of parallels and overlap between the work that PSI is doing and the work that CCP is doing in Tanzania. It's really nice to see. So my question for all right, let me see if there's any questions in the chat that have come up for anyone, or would anyone like to raise their hand and ask a question before I ask another question of all of the participants, or of all of the presenters? I have to wait 7 seconds to give people the opportunity. So something that all of these interventions have used some form of applied design thinking or human-centered design. And a question, we all, I think most of us, or many of us who are attending today, are familiar with design and the value that design can bring. And particularly, we're very confident that what we design will be very relevant for the people with whom we have designed. At the same time, as we are all have a mandate and a challenge to work with models that can be replicated, that can be scaled. And I'm very curious about how you are dealing with these tensions between something that is highly appealing and bespoke, but at the same time can be scaled and replicable. And how do how universal do you see these interventions being beyond the context in which they were designed and developed? So that's a question for all of our presenters.
Maybe I'll jump in. I was waiting for Aissata to go first. Yeah, it's a great question. Thanks, Manya. And I think, you know, we very much tried to think this through at the beginning, since actually the funding for this effort is through core funding from USAID Washington. And the mandate for that is that it must have global significance and ideally have global applicability. And so we first tackled it in Tanzania to think about what might work in a private sector facility, a faith-based facility, but very much planned that, as I mentioned, that the Ministry of Health would be involved, so it could be potentially scaled in Tanzania. But I think we also thought about some of these very basic elements, particularly around compassion, that no matter where you are, matter. You know, the basis of human connection, kindness, caring for one another, you know, are transferable, certainly. I don't think we would ever say that you could just take this package and apply it to another country without further adaptation. But I think some of the insights that came out from providers, and certainly that came out from the research that CPRC colleagues led early on in their project, are fairly common across facilities. So whether you're in a hospital or even a health center, again, some of those human elements don't seem to change all that much. But I loved what Aissata shared, that, you know, the last quote about the midwives, and sort of, you know, again, all of those quotes bring home to me some of these very common human elements. Yeah, so anyway, I would love to hear more from her.
Aissata.
Hi, Mania, j'ai pas trop compris ta question, désolée.
C'est pas grave. La question c'est, est-ce que vous pensez que cette intervention peut être utilisée dans d'autres pays ou bien d'autres contextes? Ou bien c'est très localisé, c'est très localisé? Bon, est-ce que vous pensez que
La
cette intervention
réadaptation.
peut marcher? Voilà.
Okay,
Peut marcher dans d'autres contextes.
okay, thank you, Mania. Thank you for clarifying that. I think this is very replicable, or how do we say adapted? We can adapt it in context, because what happens, like I said, we use the Johnson SMS that they sent provided about mental health, and also we use like Empathway that ThinkPlace did, I think, through with Breakthrough, and try to localize it using local knowledge, local terms about mental and emotional health. Taking from what we live in Mali, what midwife lives in Mali after we heard it, and trying to involve them in the process of adapting. So I think it's very possible to adapt it, and using it in Ghana is a proof that it can work, even though it's maybe related to the fact that Ghana and Mali may have similar context. But I think she, when Lynn said the human factor, because who doesn't want to have somebody who can hear your troubles and stress and trauma and try to talk through and sharing what they have had in a context where you feel like this is a safe space I can share. So I think it's very adaptive in any context, but we have to think about the local context about mental health, emotions and stress, and what are the needs. Thank you.
Yeah. So what I'm hearing you saying is that there is a universality across the challenges and some basic human desires for connection, for safe space, for sharing, for support, etc. And that there may be some exercises in adaptation to make sure that the language that you're using, the images that you're using, that there is probably some process of adaptation to make it work, but not necessarily that we would have to go all the way back to the beginning and initiate a design practice from A to Z every time that we're moving an intervention into a new context. So thank you so much. Andrea, you've had your hand up for a very long time, and I want to make sure you get to ask your question, so go ahead.
Thank you, Manya, and thank you so much to the presenters for your really great work and delivery. I'm wondering if any of you had operational learnings that led to adaptations mid-course. You know, I think we often focus a lot on the design phase, some of the theory and the behavioral pathway, but I'm wondering if you had any implementation learnings about, you know, how you could scale or where you maybe tried to deliver through one certain channel or platform, maybe even a certain type of meeting that didn't really work and you course corrected along the way. So I'm wondering if you had any operational learnings that you might share.
Can I go ahead?
Yes, please, Aissata, go ahead.
Okay, thank you. For the Mali context, initially when we did design the Club Courage, we thought, okay, let's use it with the Midwife Association and they will be able to dispatch it and teach people. And at the same time, we thought it will be in the health center context where they already are and they meet. But from what we heard as feedback and seeing how it happened, the content itself has changed because the initial content and the message in the club was not like that. So we changed it and tried to merge it with another prototype that we had. And from that, the midwife, we saw that we don't need to create new clubs where they will meet, but we can just use it in existing clubs, and at the same time it's not like bound that they will meet in the center. And this came from midwife themselves. So instead of meeting at the health center, let's go out, let's go at a public place like a park and meet there and share that. Let's go to each other's home and see how each other are doing and doing that. So these are some changes we have made in the and the card themselves, the design and everything, and most of the design, the picture and stuff have also been corrected as we were trying to implement. Thank you.
Great. There's a question that is coming in for Sean from Nita from Japaigo, but I'm interested in both Lynn and Sean and Aissata as well. You talked about recognition and celebrating success as part of the components of this model. Both of you did. Could you guys give some examples of some of the mechanisms used for this? I think for Lynn, we saw that there was the client feedback forms and that data was coming back. Sean, would you like to share some of your recognition techniques?
Sure. You know, I guess what I would start with is we had initially included incentives in that category, and Department of Health was very anxious about anything that would create an expectation that couldn't be sustained. So we backed away from the idea of incentives, and initially we thought, will recognition be enough? But what we've been doing, and I've been part of some of them, are quarterly review meetings with the clinic teams where everyone comes together that week, and instead of the training, we go over the patient survey data. And I've seen clinic teams break into applause for themselves when they see that the number for the quarter is higher than it was last quarter. So, it's really a very simple and intrinsic thing that just by reflecting their own progress back to them, it's really quite a celebratory environment.
Mm-hmm.
Yeah.
And one of our behavior change technique tactics, right? One of the proven behavior change technique tactics. So that's really great. Sean, are you guys still doing the postering and the complement a provider element as part of that intervention?
We are, one of the things nurses said is the very best part of my day is when a patient tells me I made a difference. And so we developed some posters that try to encourage that. And we also borrowed the idea of a gratitude board, which is like a big whiteboard that folks can write on. Candidly, I think we're facing some further behavior change challenges on that in trying to convince patients that that's something that's okay to do, something okay to use. I think it's a very embedded dynamic here that the patient is really just supposed to sit quietly and listen. So the idea that, no, you should actually speak up and the nurse actually cares what you have to say, we're hoping will gain traction over time. It's been a little challenging.
Thank you so much. And Lynn, was there anything else you would like to share or add a little bit of detail on that element of recognition and celebration within the Tanzania project?
Sure. Yeah, we started out, and maybe this touches a little bit on Andrea's question too, that we started with sort of this certificate of recognition and then a photo that providers thought it'd be nice to see their own photo taken, put in a frame sort of up on the wall so that they could get that recognition. And then when we had the adaptation workshop to really pause and see what worked and what didn't, it turned out that in fact, many of the in-chargers were not giving the certificates to the providers. They felt they needed to keep them. They also then had questions about whether or not they did want their photo on the wall, because some said, well, if my photo's on the wall, then more clients are going to ask for me, and that might make, you know, my day longer or the queues longer. And instead, what they said is, you know, recognition absolutely counts, and that champion of the month matters. And they wanted a very small token of appreciation rather than the photo. They decided instead they would prefer a bar of soap or a bit of sugar or even just a notebook, so that it was something tangible that they could take home to their family and sort of be recognized at home, that they could say, hey, I was, you know, I performed really well this month and this is what I received. So we changed that. We also changed actually quite a bit about some of the forms. The provider self-assessment had a section at the end where they were supposed to ideally give feedback to the in-charge and to the facility. So, you know, for example, if they felt more supported, that was wonderful. But if stockouts were still an issue, you know, how would they be sure that they could convey that? And it turned out that it did not work at all. Providers were afraid to write down on that form what their criticisms were, because they were afraid that if they wrote it down, it could be put into their file and that they could be sort of punished for it later, you know, as part of their reviews. So we removed that part and changed the training to really practice on giving and receiving feedback, not just in that kind of hierarchical, whoever is in charge telling me what I've done wrong, but that the lower level cutters could give feedback sort of up the chain, if you will, and much more emphasis on positive feedback. You know, Sean's note in the chat there that, you know, if you're only using a checklist of like, you didn't do this, you didn't do this, you didn't do that, you know, it can also be quite demoralizing, that we need to pause and find those moments where someone did something really well and make sure that they know it, have heard it from you, and know that they have been seen and recognized.
You know, and in so many ways, that's a behavior that then can also reflect with clients as well, celebrating clients and their wins and their small, you know, the progress in the wins that long-term care clients might want and need. So I love that. I love that turning towards the positive and looking at recognition rather than shame. I mean, we know, right, that shame shuts people down, and shame actually creates a feeling of threat that often makes us unable to fully access our cognitive abilities. So fantastic. I'm seeing some really fun conversation going on in the chat, people talking about their practical ways that they are reflecting or echoing some of the themes that we're hearing in these presentations. And it's so exciting when we see that across our community that we're having similar insights and that we're growing together, sometimes in parallel, but that we're growing together in parallel. So it's very exciting to me to bring us together to begin to cross-pollinate across these different approaches and interventions that definitely have things in common and that echo one another. Also, the fact that these are happening in very different countries and contexts helps us to see that really this is something that, you know, whatever it looks like in a particular setting or a particular district, that these concepts and this very practical approach is something that is working across contexts. So that gives us a lot of encouragement, I think, for the scalability of these things. I think that we're probably close to time. I want to make sure. Kendra, how am I on time?
Yeah, so we're at the end. I can do a quick wrap up, but I'm just thrilled at how engaged this whole discussion was. I feel like there was so much that we took away from today's conversation, and please don't stop in this meeting. I'm hoping, as we shared earlier, we're having a knowledge cafe in September, which gives more opportunities to engage and have conversation and learn from one another, and really support the building of this SBC and service delivery area. Next slide, please. We just want to thank you for coming today. I'm going to launch a poll as I wrap things up. Let's see. Okay. Just a quick poll just to see what you thought of this meeting today. As I shared at the top of the meeting, or I'm sorry, CK shared, that today's meeting really focused on provider-driven behavior change, and the objectives from today's meeting were to share and discuss results from the Community Practice Sustainability Survey, learn about 3 programs working to support provider-driven change to improve service delivery, discuss opportunities on how to incorporate provider-driven change into COP members' SBC, health system strengthening, and or service delivery programming. If you have additional feedback or inputs to help us develop the sustainability plan, please email me, Kendra Davis. I just put my email address in the chat. And then Heather just shared the Knowledge Cafe survey, and we would love to hear from you. We will be sharing the meeting recording, the notes and presentations probably next week, and more information about the upcoming Knowledge Cafe. And as we shared, the Knowledge Cafe is an opportunity for you to either learn from tools you're interested in, getting a bit more information on, as well as share tools that you and your team have been working on. So with that, we'll close out today's meeting. There's a minute left to complete the meeting survey. And yes, as Heather said, thank you to the wonderful presenters. It is just so great to see that there's continued effort and growth and development in provider-driven change. Provider behavior change is the #1 area, as we saw earlier in the survey results, that our members are working on. And it's just so encouraging to see. And I hope members that as we're developing our new work plans, we can think of ways to adapt some of the things that we learned today in our work.
Thanks all. Bye.
Thank you so much,
Thank you and
everyone.
bye.
Have a lovely rest of the week.
Thank you and bye.
Thanks, folks.